All right. Good morning, good afternoon, and good evening, depending on where in the world you are joining us from. My name is Sarah Webb. I'm with the Reproductive Health Supplies Coalition. I'm just going to go through a couple of logistical details before we get started with our webinar today. For those of you who have not joined an RHSC webinar recently, you might not be familiar with our new translation software. I'm dropping a link in the chat right now for software called Wordly. And with this software, if you follow the URL, you'll be able to click into a website that will do captioning, or you can select to have the audio play, and you can choose over 50 languages that you would like to have the webinar translated into. So please do feel free to use the translation software. And if you have any issues with the software throughout the webinar, you are welcome to reach out to me or my colleague, Raina, who is also on the line. And then the second logistics piece we wanted to cover before we jump right in is that throughout the webinar, if you have questions, we strongly encourage you to put your questions in the chat. We will be more than happy to take questions throughout the webinar, but there is a special time at the end for questions, so we'll probably refer most of those questions to the end of the webinar. And with that, I would like to hand it over to Andrea Fernio, our Safe Abortion Supplies Workstream co-chair. Over to you, Andrea.
Great, thanks, Sarah, and welcome everyone. While the last few folks are joining, why don't you take a moment and introduce yourself by sharing your name and organization and where you're logging in from in the chat. I see some people have already started to do that. We're here today to do a deep dive into the LEAP model. LEAP stands for Landscape and Projection of Reproductive Health Supply Needs, and it is a model that estimates future use, so volumes, and the cost, the value of reproductive health supplies in four key health areas: contraception, menstrual hygiene, maternal health, and the reason we're here today, abortion and post-abortion care. In this deep dive, we will learn a lot about what the LEAP model has to tell us about safe abortion and post-abortion care, noting that the LEAP model was just updated with new capacities added. In the reproductive health space, I think as many of you know firsthand, safe abortion is rather unique. It's highly stigmatized, and post-abortion and abortion supplies, MBA kits, medical abortion drugs, are often obtained from the private sector or NGOs in many countries. These factors combined make it challenging to understand the scale of supplies needed to meet people's abortion and post-abortion care needs. The LEAP model addresses this challenge and is a fantastic tool for advocates and implementers. So get ready. This will be an interactive skills building webinar. There will be a couple of Mentimeter surveys and an opportunity to use the model, to demo the model, as well as to ask questions as we go along on this deep dive. So over to our colleagues, Megan Reedy and Michelle Weinberger from Avenir. Avenir developed the LEAP model for RHSC. So we've really got the experts here taking us through this. So over to you.
Great, thank you, Andrea. So as Andrea said, we really hope that today is a sort of interactive learning session. So we're going to first start with just a brief overview of the LEAP report for those who are not familiar with it, to just sort of ground us in what LEAP is trying to do. We're going to look at some key results from the abortion and PAC section of LEAP. And then we're going to dive into exploring some variations that we see in the data across both income groups and regions. We're going to showcase 2 new data explorer tools that can help you get more out of the data. And then finally, save some time at the end for question and answers. And we will be doing a few Mentimeters throughout to just get more engagement from you all. And you can access the Mentimeter either through the QR code and the code you see on the slide, or also there's a link in the chat. So I'm going to start with just a broad introduction to LEAP, but before we do that, we thought it would be useful to just get a sense of those who are with us today's familiarity with the LEAP report. So if you go into the Mentimeter you should be able to answer this question. There are no right or wrong answers. We just want to get a sense of how people have used LEAP before and how familiar you are with it, which will also help us a little bit set the tone of how much detail to go into today. We'll just give folks a minute, and hopefully, if technology cooperates, we will start to see some responses on this slide. All right, we might be having a
Like technical difficulty.
Technical challenge.
Because it is showing up on in the Menti online, but not in this presentation. So they're actually we have 6 responses saying that they have reviewed it, and 4 saying that they are somewhat familiar with the report. But
Great. All right, we'll see if we can get that working for later in the slide deck. So as Andrea said, LEAP explores supply needs across 4 different areas. LEAP has a long-standing foundation as the contraceptive commodity gap analysis, which was produced for over 2 decades by RHSC that focused just on contraception. And then back in 2021, we made this step to expand our remit and look not just at supply needs for contraception, but for supply needs for menstrual health, abortion and PAC, and maternal health. And while the results in LEAP are presented separately for each of these, you'll see there's sort of a set of reports for each of the different health areas. The analysis is interconnected in the background. So we're accounting for the relationship between these different supply needs and changes over a woman's lifetime. So for example, changes in contraceptive use, increases in contraceptive use, reduce the number of unintended pregnancies, which influence the supply needs for abortion, post-abortion and care, and maternal health. And we also have other interconnections. So for example, the use of hormonal contraceptive methods influence or reduce bleeding, which influences the need for menstrual health supplies. So there's a lot of connection happening across these, recognizing that these are sort of fluid needs across a woman's lifetime. Across the 4 health areas, we present similar results. We start with the people who are using or needing the key reproductive health supplies. We then look at the volume or quantities of drugs and supplies needed, and then finally look at the cost of those. We look at a current landscape, which for this version of the report is 2023, and then we project forward 3 different future scenarios, exploring different key questions to the community to help inform discussions about where things might go and the impact of different changes. And we look at those future scenarios out to 2035. Our analysis covers 132 low and middle income countries. We present results overall and by region, and also segmented into country level income groups. So low income, lower middle income, and upper middle income based on World Bank classifications. We also have country level data, but for abortion and PAC and maternal health, at this time, those country level results are not shared. We can discuss that more later. We use a wide range of data sources, as you can see here, drawing from surveys like DHS and Mix, drawing from research, drawing from all sorts of different sources to look at prices and sales volumes, as well as population projections. And so all of this comes together to produce our estimates for LEAP. Just one note, particularly for abortion and PAC, we're leveraging this year some new private sector pricing data coming from online searches of pharmacies, as well as through a partnership with Maisha Meds. We also purchased some new data from IQVIA, which helped us really get better visibility into what's happening around the use of mifepristone and combi packs, which we'll talk about a little bit more later. We also incorporated new work from colleagues at the Guttmacher Institute around estimating the level of abortion, so getting to our kind of estimates of the total abortions that are happening. A few other updates for those who are familiar with the 2021 results is that we expanded our projections to go out to 2035. We have new data sources to better capture the use and cost of medical abortions, being able to differentiate between misoprostol combined with mifepristone. We have an added analysis on combi packs. It's not part of the main report, but is sort of featured in a text box, and we'll take a look at that later today. And we also made some changes to the future scenarios based on feedback from the community. We've also changed how the report is structured to make sure that the data is really easily accessible. And so LEAP now has two main reports. So when you go into LEAP, you'll see these front and center, an overview report, which is a dynamic report that can be viewed for any selected region, as well as a global GNI comparison report, which focuses on highlighting differences between low, lower middle, and upper middle income countries. There's also these two data explorer tools, which we'll look at a little bit later today. And for those who just want to get to the numbers, you can get those either through a series of key annex tables or just downloading all of the data in an Excel file and being able to play around with it yourself. So really trying to make sure that the data is front and center and accessible to lots of different folks who want to use it in different ways. So with that, I will pass over to my colleague, Megan Reedy, to talk us through some key results from abortion and PAC.
Thanks, Michelle. As I'm sure you all know, the variation in access to abortion, as well as the stigma of these services, has created great variability in the safety of abortion services. The WHO classifies abortions as safe, less safe, and least safe. In LEAP, we have modeled all three types of abortions, as well as post-abortion care services, to complete an incomplete abortion or miscarriage. However, we have only costed a subset of supply-driven services. So this includes safe and less safe abortions, as well as post-abortion care services using medical methods, including misoprostol alone and in combination with mifepristone, as well as vacuum aspiration methods. We have not costed least-safe abortions and surgical services using dilation and curettage and dilation and evacuation. Throughout, we refer to the number of services, as one woman may receive multiple services. For our 2023 baseline, we've modeled a total of 65.8 million abortion and post-abortion care services, including all of these three safety types and all the methods. The majority, 82% of these services, are abortions. Looking at the distribution of services by method, the share of costed services increases with income. So least safe abortions, which are not costed, are represented here in dark gray at the top of the bar and account for 11% of services in low and middle income countries. Medical methods using misoprostol or a combination of misoprostol and mifepristone make up the largest share of services at 43%. Next slide. We have modeled a total of $273 million in supply costs, which is primarily driven by the cost of misoprostol, shown here in the darker pinkish bar at the top. Medical methods account for 90% or more of total supply costs, while vacuum aspiration, which only includes the cost of the MVA kit, is a very small share. Misoprostol alone accounts for 67% of the total costs. Next slide. Looking towards changes ahead, we modeled three potential future scenarios. The first scenario includes demographic and contraceptive use changes from other sections of the LEAP analysis, as Michelle described. No changes were made to the distribution of the safety profile of services or the surgical and medical methods. The second scenario takes the first and improves the safety profile of services, decreasing the proportion that are least safe and increasing the proportion that are safe. And the third scenario takes the safety improvements from the second scenario and adds a shift to a greater use of medical methods, particularly using a combination of misoprostol and mifepristone. The next slide. On the side here, you can see the impact of these changes, with the first bar representing the no change scenario, scenario 1, the second representing the shift in safety scenario, and the third, the shift in safety and method profile scenario. The share of services that are least safe abortions decreases in scenarios 2 and 3 from the 11% in scenario 1 down to 4% by 2035. And in scenario 3, the medical methods would make up 50% of all services by 2035. Next slide. While the total number of abortion services increases by the same magnitude in all 3 scenarios, what differs is the number of services that are counted as costed because they are safer, as well as the change in post-abortion care services based on the shifts in safety method profile. However, the general pattern of change in total abortion and post-abortion care services is similar in all 3 scenarios. With no changes in the safety or method profile, as in scenario 1, the number of vacuum aspiration and medical services would both only slightly increase. A more substantial increase in surgical aspiration services would be seen if there was a shift in the safety profile, as in scenario 2, seen here in green. However, most of the increase in surgical services would be offset if the method profile also shifted towards medical methods, as in scenario 3, seen in purple. Next slide. Looking at the impact of these changes on supply costs, you can see substantial differences between the 3 scenarios and the change in cost between 2023 and 2035. In scenario 1, the costs would slightly decrease. In scenario 2, it could lead to slight increases in costs as a larger share of services are safe or less safe and get included in the cost of services. Scenario 3's shift in safety and method profile with more combination misoprostol and mifepristone could lead to much higher costs if there is not a decrease in the price of mifepristone between now and 2035. And it's easy to apply today's prices to growth projections a decade away and view that as a looming bottleneck to growth and access. But it is also just as likely that increased demand will give way to increased competition and ultimately lower prices, and such a decrease is very possible. The future market for mifepristone and medical abortion more broadly will also be shaped by a range of enabling factors such as country policy decisions and product registration. Ensuring availability of affordable, high-quality abortion services is critical to enabling a woman's access to safe abortion care. And now I'll hand it back over to Michelle to look at some of the variation between income groups and regions.
Thanks. So the results Megan just shared were the overall aggregate for all low and middle income countries, but these aggregates hide wide variation. So now we're going to take a little bit of time to start to look into some of that variation. So looking at the distribution of services by method across the income groups, we see that the share of costed services increases across income groups. So with just 65% of services being costed services within low-income countries, 77% in lower middle-income countries, and 86% in upper middle-income countries. And we see that this is really driven primarily by the role of least safe abortions, which proportionately play the largest role in low-income countries and the smallest role in upper middle-income countries. Across all income groups, medical methods using misoprostol or misoprostol in combination with mifepristone make up the majority, accounting for just over half of costed services, 54% in low income, 58% in lower middle income, and 51% in upper middle income countries. Here, we're comparing the absolute number of services on the left by GNI group with the cost of supplies to the graph on the right. We observe some interesting differences when we compare these two distributions. We see that in absolute terms, the greatest number of services take place in low and middle income countries, with just under half of all services taking place in this group. This is driven both by population and demographic factors, as well as by level of abortion that is happening in countries within that income group. However, when we look at the picture of cost, this looks quite differently. We see that the costs of abortion and post-abortion care supplies are highly concentrated in upper middle income countries. They account for 65% of all costs, and this is largely driven by the cost of misoprostol, and we'll come back to look a little bit more at costing in a bit. And so just to say that it's useful to think of these markets in different ways, because we often see very different views than when we think about them in terms of the number of services that are happening versus in terms of the monetary value of those services or the cost of those services, in most cases, to women who are accessing them. In addition to differences by income group, we also see differences across regions. So here we're looking at results just for some select regions, and on the online tool, you can look across all different regions of the world. So we see that the role of medical methods varies. So with 34% of services using medical methods in sub-Saharan Africa, up to close to half in South Asia. We also see differences, and you can see this between the darker shade of purple and the lighter shade of purple, of the role of mifepristone. So we see that there is a much more significant role of mifepristone in Asia, and almost a non-existent role in Latin America and the Caribbean. So almost all medical abortion services that happen in Latin America and the Caribbean, based on the data we have access to, seem to be done with misoprostol only, versus a larger role of mifepristone in Asia, and a little bit of a larger role of mifepristone in sub-Saharan Africa, but not to the same degree that we see elsewhere. So I mentioned before that we did some looking into combi PACs. So this was not integrated into the main results, but sort of explored as a side analysis and presented in a text box within the report. And we also see a really large variation in the role of combi PACs. So we estimate that overall, about 50% of services that use misoprostol and mifepristone together are using a kind of packaged combi PAC. So they're packaged together with some sort of branding on it. But we see wide variation. So less than 10% of services in East Asia and the Pacific are using combi PACs. So the others, the misoprostol and the mifepristone, are just sort of purchased separately and used together. To around 2/3 in sub-Saharan Africa, to almost all services in South Asia being done with combi PACs. So really differing markets in terms of what those services using both misoprostol and mifepristone look like. And then finally, we also see very large variation in price. For LEAP, we use country-specific price data where we have it and regional averages where we don't. The data presented in this table is sort of the resulting regional averages using our LEAP estimates of costs and comparing them to quantities. So these are informed by both those country-specific and that regional data. We see that Latin America and the Caribbean have the highest prices for both mifepristone and misoprostol. Mifepristone is nearly 8 times more expensive than the least expensive region, which is East Asia and the Pacific, and misoprostol is 28 times more expensive than the least expensive region, which is South Asia. Generally, we see the lowest prices in Asia, potentially due to the presence of manufacturing in these regions. So we've just seen a lot of variation of results, and we wanted to kind of pause and get some thoughts about why we see so much variation in these markets. So we're going to go back to our Menti. I don't think, unfortunately, we're going to see the results here, but we can, Lucian, it looked like you were able to drop that into the chat for us, and maybe Megan can read off some of what we're seeing. So just wanted to get
Michelle, if you want, I can switch and present, and it should be able to show the results.
Perfect. Okay, I will stop sharing and let you share. Yeah, so folks want to think about why we might see so much variation, both in terms of use, so the different role of medical abortion and the different role of mifepristone, as well as differences in cost. Megan, it looked like some responses were there, but now are not showing.
There's one.
Sorry for the technical difficulties. All right, Megan, do you want to reshare?
Oh, is it not? Sorry. I thought I was still sharing. Let me go back because we are getting plenty of results.
There we go. All right, technology is now working for us. Great, so we see lots related to policy and legal restriction, kind of the presence of manufacturing, market dynamics, the role of stigma and other socioeconomic factors. Great. So yeah, so we just thought it was helpful. I think LEAP can be used in lots of ways, but I think kind of observing some of these stark differences is helpful, and then thinking about where there might be room for advocacy or different types of market interventions to maybe address some barriers and think about how we can ensure that there is equity in these markets.
Right. So I will now take over and show us some of the additional tools that were recently released as to accompany the LEAP report. So there's two components, the Regional Comparison Data Explorer and the Product Deep Dive Explorer, and I will go into both of them. So to start using the Regional Comparison Explorer, you use the drop-down menu to select the regional grouping of interest. For abortion and PAC, as well as maternal health, we're only showing regional estimates, unlike the contraception and menstrual hygiene, where we're showing countries. So here I've selected the World Bank classification, but you can also look at it by the UN POP division classifications of country groupings. So you can interact with the figure to explore the data in different ways. For example, here in this graphic on abortion and PAC services is showing the number of services in the different types of services of different types in the World Bank regions. And it shows the largest number of services in East Asia and Pacific, followed by South Asia, which of course not surprising given that those two regions include China and India. And you can toggle, you can see in the circle on the bottom right between absolute and relative. So when you see it in a relative, you can see sort of the percentage distribution. So the proportion of the different types of services with South Asia having the highest proportion of medical method use. And there in the orange circle on the bottom left, you can see where you can switch between services and costs. And then shifting to costs, you can see the 2023 estimated costs in absolute terms. This information can also be downloaded as a CSV file, or you can download the graph image itself as a PNG file. When looking at the projected changes, one can select the indicator, the product, and the scenario to see the projected changes from 2023 to 2025. So this graph here reflects the estimated changes in the costs of medical methods under scenario 3. So it's seeing the shift in safety profile and method mix scenario. You can also compare different scenarios in a given year. So here, 2035, showing the costs here of medical methods differing by the 3 scenarios in each region, with the lowest costs varying by scenario and region, but with the highest costs consistently seen in scenario 3. And then for the product deep dive tool, it lets you focus on a particular product among misoprostol, mifepristone, and MVA kits. And then you select the regional grouping to see these comparison results. So here you can see the future estimated number of products needed over time in the different scenarios, with the largest quantities of misoprostol needed in scenario 3. You can also look at the product distribution by income group. So looking at misoprostol with this tool, we can see that most of the units of misoprostol are used in that the highest number of units of misoprostol are used in lower middle income countries, followed by upper middle income countries. So in summary, we want to ensure that the data underlying these different tools and graphics are accessible to users. The data on the current status and future projections are available for all low and middle income countries, as well as all low and middle income countries, but grouped in their respective regions, income groups, and donor priority groups. As mentioned previously, all graphs can be downloaded as PNG files and the underlying data as CSV files. And the key annex tables provide a summary of the main results for any selected region and are available to download. Finally, for advanced users, the entire data set can be downloaded and used for further analysis. And then we wanted to take a quick temperature check to see how you think you might use the LEAP report in the future. You can vote for one of these selections, or if you have any other ideas of how you might use it, please feel free to enter it in the chat. And as you're voting here, please think of any questions that you might have and put them in the chat. We've got lots of time for a question and answer, and we'd be happy to talk through results more. Looks like we've got lots of votes for using it for advocacy, for increased investments in safe abortion, market sizing, a few votes for understanding regional patterns of use, a couple others. I don't know if someone who can see the chat would want to read off those other suggestions.
They're not in the chat yet, but for the folks who said other, if you want to drop a note in the chat of other types of uses that you envision, that would be great to hear.
Well, it's really great to see that people are thinking of different ways in which they'd be able to use these data. I think the most important part about this tool is that we've made the data so accessible and easy for everyone to use. So hopefully everyone will be able to figure out how to use it. And if not, on the last slide, which we'll get to after people are done voting, there's an email address that you can write to if for some reason you're having difficulty accessing results. So we would be happy to help you with any technical difficulties that might arise while you're trying to access these data, because we really want to make it easy for everyone to use. And please, if you do have any questions, feel free to put them in the chat. We'd love to answer them.
Yeah, thank you so much, Megan and Michelle. I think as we wait for some questions to come into the chat, I wanted to kick us off with one. So I know Megan and Michelle, you are very familiar with this data at this point, and just with the LEAP report overall and for many years. I'm wondering if you have any reflections in sort of creative ways that you have seen the LEAP report and the LEAP data be used for advocacy. Is there kind of strong examples you have, either from the abortion data specifically or just kind of more broadly within LEAP, that are top of mind for you?
So I don't have examples from the abortion section, but would love to hear from those participating today if they have used it. But we have some great examples from the other section. I think menstrual health is a great example where a lot of the data has been used in advocacy efforts around getting a separate ISO code for menstrual health products to kind of show the size of the market and the importance of tracking it separately. And a lot of the menstrual health report explores in its future scenarios and increased use in reusable products, so like cups and reusable pads, and know that that has been used by advocates to sort of show the potential value of that market to help get more investors into that space.
Awesome. Thanks, Michelle. Megan, anything you would add to that?
I'm trying to think if there's that. The menstrual hygiene I know is probably the best example. I have not heard of any use from the abortion space, but hopefully forums like this, really making the results available and walking users through how to access the results will help prompt people to know that these data are there and be able to use them more in the future.
Yeah, absolutely. Thank you, Megan. Thanks, Michelle. So we do have a couple questions popping up in the chat. So the first is, how did you estimate the portion of MIFE and MISO services which were provided using PAC versus the two products separately?
So for this analysis, we worked with some data that we purchased from IQVIA. We worked in partnership with some SMOs and also with Meds, and took the data that we also had from the IPPF. I don't remember what I'm blanking on what the database is. Oh, the Medical Abortion Commodities Database, to look at availability of different products in the country to try to estimate the relative proportion of the products that were in combination as opposed to being used separately. It's really kind of a triangulation, given sort of our estimates of the number of abortions that took place and the number that took place in combination relative to the number of supplies that we actually were seeing in the market.
Awesome. Thanks, Megan. There's another question in the chat from a bit earlier when we were going through the regional comparisons, wondering why in sub-Saharan Africa the mifepristone numbers were so low, and if you have any insights into why that might be so low in sub-Saharan Africa.
Go back to that. Was it in terms of the number or the price?
Just like this. I think in terms of the number, it sounds like.
The number, yeah.
All right. So I know that there's been a lot of recent shifts that we're still trying to capture in the data. Because we're sort of relying on the data that we have access to through either through SMO partners or from what we could purchase from IQVIA. Unfortunately, IQVIA doesn't cover a lot of the markets in sub-Saharan Africa. So, we sort of had to work with the data that we had and, sort of triangulate from different sources. We also used estimates from Adding It Up as to their proportion of services that were used with combination meso-MIFI. But we actually, based off of the data that we had from SMOs and Meds and IQVIA, we inflated those percentages quite a bit from what was in Adding It Up to reflect the recent increases. And I think given that we were working with reported data, I think those numbers are only going to keep increasing.
But I also think, and this came up in some of the responses about the variation, right? You have a lot more restricted environments where registration of mifepristone is a greater barrier than you have in other places. And so I think its entry into markets there has been maybe more challenging than in other places. But as Megan said, seeing kind of promising signs of increased access to mifepristone, largely driven through increased combi PACs in that region.
Awesome. Thank you both. We have another question in the chat for both of you, so we'll allow you both to answer. But what surprised you the most about the data? Was there something that jumped out at you as particularly surprising, or perhaps that you didn't expect in the abortion data?
I think the biggest surprise was what we were just talking about, like sort of the shifts in MIFI that we had since the data that was available for the 2021 report. For the 2021 report, we were very much just kind of modeling, but for this one, we had a lot more data to inform the results and see that real shift to more MIFI use. And I know relative to South Asia, it's small, but it is in reality a big increase over time.
Yeah, I think one of the things that jumped out is how different things look in Latin America and the Caribbean. And I think we see this across a lot of the different LEAP reports. I mean, it makes sense that their markets are very different, right? You have a much more kind of private market, less role of SMOs and donors and other partners. But I think how that manifests is often quite different. And so particularly here, I think the lack of much mifepristone in that market is interesting, and would be curious for folks who work in that region to maybe hear more thoughts on that. Also, the higher pricing we see there is something we also see in other regions as well, but just really stands out, especially for misoprostol, of just the huge price differences that we're seeing relative to other places. So expected some differences, but maybe not quite as stark as what we saw in the end.
Awesome. Thank you both. We have another question in the chat asking what is next, and are there more data cuts or views planned for this year?
So we don't have kind of new analysis planned for this year, but I think our hope is to just really support. There's so much in the report, and just really make sure that gets utilized as much as it can. So look forward to more opportunities of working with advocates and with others to make sure that this data is really integrated into different efforts, and do what we can to help kind of get it into analyses that can be useful for everyone in the community.
Megan, anything you would add there?
As Michelle said, we don't have any new analyses planned. This is, the two new tools that we just added were sort of our final rollout as a part of the LEAP report. So, I think we're, as Michelle said, focused on now, people using the tools now that we have them launched.
Awesome. Thank you so much. We have had a couple questions, in the past, Michelle, as we've been putting the report together, and some consultations, including with the Safe Abortion Supplies Workstream, about the LEAP report at the country level. So I know in the report right now, both the menstrual health supplies, the contraceptive supplies do go down to the country level. The maternal health supplies and the safe abortion supplies remain at the regional level. Do you have any insights kind of into those decisions, and whether country data is something that would be looked at for the future?
Yeah, so the report or the analysis is built up from the country level, but we have had some hesitations about sharing that data for a few reasons. One is that, unlike for contraception and menstrual health, we are very reliant on a lot of regional assumptions for a lot of these things. That's starting to change, right? We now have Thanks to the work of the Guttmacher Institute, there are country-specific estimates around abortion incidents that we're able to utilize, and starting to get more data that lets us get kind of more country-specific. But I think our hesitation has been around, I think if we shared the country level results, we would want to share them with a lot of caveats about, where they're informed by regional data and not country specific data. And especially given some of the sensitivities, right, in countries around abortion, I think that just makes it even more important that we're really thoughtful about how we share country results. So I think it's something that it would be great to have discussions, within this community about it. I think we just want to make sure that we're not sharing information that is misinterpreted and then is somehow, having negative consequences for having that out there. And so it's, it is there. It's just about making sure that everyone is comfortable in having those results out there and being able to really appropriately provide the context of what they can tell us, what they can't, what their limitations are.
Yeah, absolutely. Thanks, Michelle. Yeah, Megan, go ahead.
And it was very much a collaborative decision to come to that decision to not share the country level results. So we did do a lot of stakeholder consultation within the community to make sure that, the decision that we made was sort of widely agreed on. But I know, for advocacy purposes, it's so much more helpful to have those country level results. But we have to balance out the potential of causing harm, and because that's what we really don't want to do.
Yeah, no, absolutely. Absolutely. And I think too, as people, continue to use the LEAP report and start to implement, different advocacy asks or efforts sort of associated with the report, better understanding some of those use cases and the way that people might be using these data to inform decision-making or to inform sort of advocacy work, will just help us have that conversation in the future as well. So a plug to everybody on the line, as you do use the report, if you have certain reflections, certain use cases of how you're using it, certain reflections on that. I know Michelle and Megan, as well as the RHSC team, are always open to hearing those. So please do drop us a line if you have any feedback as well. Any other questions? I think we have caught up with the ones in the chat.
There's one more in the chat.
Oh. Yep. Thank you. One more that just came in. Thank you so much, Andrea. Yeah. Are there plans for periodic future updates to the data?
Yes. So we've been roughly on a 2-year cadence of updating LEAP. Got a little off in the COVID era, but yeah, I think the anticipation is that so I guess that there would be a 2026 LEAP update. That would be incorporating new data sources and then potentially updates to the methodology. Before starting the 2024 round of updates to LEAP, we did quite a lot of consultations. So we had discussions with workstream members. We did a little online survey to solicit additional input. So the expectation would be that a similar process would be followed to kind of gather information about how the report is being used, but also what could be different. So is there new data we want to be incorporating? Do we want to think differently about how we do our future scenarios to make sure that they're aligned with, current discussions? Are there other critical issues that are really front and center in the community and that we want to think about how the LEAP analysis could touch on? And then build that update in on top of just, updating data sources, using the most recent data that we have, but also hopefully being responsive to those shifting and evolving needs as well.
Great. Any other questions from our webinar participants? Anything else that you want to know about the data? Maybe while we wait for any kind of final questions to trickle in, I think one question that I have for both of you is if everybody on this line were to leave here today with kind of one key message, whether it's about something in the data, about the LEAP report itself, what would you want people to know? And would there be any sort of call to action that the two of you would have for all of us in how we use this report?
I would say just, there is this wealth of information out there, and just knowing that it's there, and hopefully seeing opportunities to connect it with work that is happening. I think we often think like, oh, we just don't know much about pricing, or we don't know much about kind of use of different products, but they're actually, we've been able, by going to lots of different data sources and kind of pulling things together, I think, to paint a fairly comprehensive view of a lot of this. And so the same, there is a lot of information out there. And I just love to work with everyone to think about how do we make sure that that is useful to you all and can get plugged into various advocacy and market strategy efforts that are happening.
Thanks, Michelle.
Yeah, I was going to say something along the same lines. Knowledge is power, and when you are dug into your own project or your own implementation, it can be really helpful to see that bigger picture, and so you might see that, MIFI in sub-Saharan Africa looks a lot smaller than I thought it should be, because I've been so focused on that, it should be a huge thing, but relative to, say, South Asia, it's quite small. And so I think it's really helpful to see your own work in the context of the broader picture, and use that to help inform your work and advocacy going forward.
Awesome. Thanks, Megan. And Andrea, as our Safe Abortion Supplies Workstream co-chair, I'll posit the same question to you as well, but any sort of call to action or big takeaway from you and how we might use the report?
I think my call to action is just go online and play around with it. It's very user friendly. You don't have to download a spreadsheet. You can if you want that, but it really, one of the things I really like about the LEAP model is that you've made it very easy to navigate. If you have a question, most often that question is answered there's kind of a briefing document or kind of notes. It talks about definitions and that kind of thing. But, instead of having to, input a bunch of information myself, I just kind of choose, do I want absolute or not? Do I want, kind of what region do I want to see? And so I really commend you for making it so incredibly user-friendly. And I think if you explore what the model can do and what's available, there'll be a lot of ideas that come into your mind about how you could use this in your day-to-day work. So give it a try.
Awesome. Thank you so much, Andrea. And yeah, just as a reminder to everybody, the LEAP report is fully available online. I know we've dropped the link in the chat a couple times through the webinar. And we did in the recent update that people have probably heard us refer to throughout the webinar. It's also available in multiple languages now. So there is an automatic translation feature that you can use. So please do disseminate widely among colleagues and partners of yours globally. And then I just want to say a huge thank you to Michelle and Megan, both for joining us today and sharing your insights and your expertise, and also in all of the hard work that you have done to produce this report. I know it is a lot of work behind the scenes that we don't all get to see often. So thank you for all of your continued efforts with LEAP, and for the collaborative process. I think to really underscore what Megan was saying earlier, the SAS workstream has had multiple opportunities to feed into this, lots of consultations and discussions with both of you. And we really appreciate that engagement and that collaboration, and look forward to any feedback or recommendations or reflections that people who are listening in today have about the report. So thank you all so much for joining. Thank you to all of our participants for the engagement, and we will see you all soon. Thanks, everybody.
Thanks.
Thank you.